Welcome to this explainer. Imagine a patient crashing in the ER, their heart simply too weak to pump. It's a literal race against the clock. Today, we're diving into the life-saving marvel of modern medicine that actually stops that clock, mechanical circulatory support, or MCS. These are highly advanced engines designed to do one primary thing: buy time for a failing human heart.
Here is our clinical roadmap for today. We'll cover the basics of circulatory support, temporary interventions for both the left and right heart, durable left ventricular assist devices, the surgical techniques involved, and finally, pediatric mechanical support. Let's jump right in.
Section 1. The basics of circulatory support. Okay, so the core distinction in this entire field really just comes down to one crucial factor: duration. Are we buying a crashing patient a few vital hours, or are we giving someone years to actually go back home to their family? Temporary devices are deployed rapidly, often percutaneously, just to bridge a patient through acute cardiogenic shock. It's a bridge to decision or recovery. Durable devices, on the other hand, well, those are surgically implanted internal pumps meant for long-term support. They give the patient the ability to actually leave the hospital, acting either as a bridge to a heart transplant or, increasingly, as a destination therapy all on its own.
Section 2. Temporary left heart devices.
Looking at our main frontline options for a failing left ventricle, you can see how much things have evolved. We've gone from the traditional intra-aortic balloon pump, which is basically just a pulsating balloon in the descending aorta, all the way to modern continuous flow devices. Think of these newer ones like tiny, high-speed jet engines. They're placed directly inside or right alongside the heart to continuously pull blood out of that failing left ventricle and push it right into the aorta.
Now, selecting one of these devices isn't just random guesswork. As clinicians, we have to carefully match the pump mechanism and its maximum flow to the patient's exact hemodynamic needs. For instance, the IABP provides maybe around 1 extra liter of flow per minute, but if a patient is actively crashing, we have to escalate. We might move to the Impella CP at 3.5 liters, or even centrifugal pumps like the CentriMag. That one pushes over 5 liters a minute, which is enough to completely take over the heart's entire workload.
Notice the striking spatial contrast in these approaches. Transvalvular microaxial pumps, like the Impella, literally cross the aortic valve to suck blood right out of the ventricle. It's pretty wild. On the flip side, centrifugal systems like the tandem heart require some complex transeptal access. Basically, a catheter goes up the femoral vein, punches right through the wall separating the atria, grabs the oxygenated blood, routes it completely outside the body, and then shoots it back into the artery. I mean, it is an absolute marvel of internal plumbing.
Section 3. Right heart and ECMO support.
Now, for isolated right heart failure, which can happen after a massive heart attack or even after you implant a left-sided device, we have very specific tools. We use microaxial devices placed right in the pulmonary artery, or we use dual-lumen centrifugal systems. And the goal here is simple but absolutely critical: suck blood out of the right atrium to lower the pressure, and aggressively pump it into the pulmonary artery so it can get to the lungs and pick up oxygen.
But what happens when both the heart and the lungs fail? That's exactly where VA ECMO comes into play: veno-arterial extracorporeal membrane oxygenation. It provides complete cardiopulmonary bypass right at the bedside. It takes deoxygenated blood, runs it through an artificial lung, and pumps it back into the arterial system at up to 6 liters a minute. But here's the fascinating clinical catch. Because it pumps blood forcefully backward up the aorta, it actually increases left ventricular afterload. It's kind of like asking a weakened left heart to push open a door while a fire hose is blasting it shut from the other side. Because of that, doctors often have to add a totally separate device just to vent or drain the left ventricle so it doesn't distend and fail completely.
Section 4. Durable left ventricular assist.
The evolution of this technology has been truly staggering. Modern magnetically levitated devices, specifically the HeartMate 3, are now achieving an incredible 87% one-year survival rate. Just let that number sink in for a second. 87%. To truly appreciate how monumental that is, just look at this comparison. Back in the early 2000s, there was this famous trial called REMATCH. It looked at patients with end-stage heart failure who were simply medically managed with drugs. Their one-year survival? A dismal 8%. Contrast that 8% with the 87% survival we see today with the HeartMate 3, and you immediately understand how these incredible machines are quite literally buying years of life for people who previously had zero options.
So you might be wondering, how did we get from those early failing pumps to that 87% survival rate? Well, this massive leap is largely thanks to the shift toward magnetic levitation technology. You see, older pumps used mechanical bearings. Think of a spinning drill bit resting on a physical ruby bearing. It caused friction, it destroyed red blood cells, and it led to catastrophic blood clots. The modern pumps, they use magnetic fields to completely suspend the spinning rotor in midair, or, well, mid-blood, I should say. This means no mechanical friction, wide pathways for the blood to flow, drastically reduced shear stress, and incredibly low rates of pump thrombosis and stroke. It's a total game changer.
Section 5. Surgical techniques and complications.
But how do we actually get these things in there? Implantation is a highly orchestrated procedure. It generally requires open heart surgery and putting the patient on cardiopulmonary bypass. The surgeon starts by literally coring out a plug of muscle from the apex, the bottom tip of the left ventricle, just to create an inflow tract. They then secure an apical sewing cuff super tightly to the heart muscle using multiple heavy sutures. After that, they insert the pump, and finally, they route a woven polyester outflow graft and sew it directly into the ascending aorta. So the heart is still beating, but the pump is doing all the heavy lifting, taking blood from the bottom of the heart, bypassing the aortic valve entirely, and delivering it straight to the body.
Now, having said all that, no matter how flawless the surgery is, success is dictated almost entirely by patient selection. Going into the operating room already in crashing cardiogenic shock or having severe kidney or liver dysfunction beforehand drastically increases mortality. The timing of the referral is everything here. We simply can't wait until the patient's other organs have completely shut down.
And the clinical journey absolutely doesn't end in the OR. I mean, these patients are walking around their neighborhoods, going to the grocery store, living their lives, but they have a literal power cable, called a drive line, exiting their abdomen to connect to external batteries. Because of this, managing these patients long-term requires constant vigilance. The most severe adverse events they face aren't usually pump failures anymore. Instead, they're secondary complications like severe gastrointestinal bleeding, right heart failure, and major driveline infections.
Section 6. Pediatric mechanical support.
Finally, we have to talk about pediatric patients, because they have wildly varied body surface areas, ranging from a tiny newborn to a fully grown adolescent. A one-size-fits-all internal pump is just impossible. This makes extracorporeal or paracorporeal pumps an absolute necessity. These are pumps that sit completely outside the child's body, connected by tubes. The Berlin Heart X-Score is a prime example of this, offering multiple size options to perfectly match the cardiac output needs of the specific child.
These specialized pediatric systems are honestly remarkable. They uniquely feature transparent polyurethane chambers. And this is huge because it allows doctors and nurses right at the bedside to visually spot blood clots forming in real time. If they see a clot, they can just swap out the external pump without ever having to reopen the child's chest. On top of that, these systems can be intricately configured to support not just standard heart failure, but children born with complex congenital defects like single ventricle anatomy.
So, looking back at our journey today, we've moved from pumps that barely bought a few weeks of life to magnetically levitated marvels, giving patients years of high-quality time with their families. Which leaves us with a pretty provocative thought about the future of this rapidly advancing field. As we move toward pumps that are fully implantable, with internal batteries that charge wirelessly right through the skin, and as those bleeding and infection complications fade away, will mechanical hearts one day actually outlast the biological ones we were born with? Thank you so much for joining me on this explainer, and keep wondering.